Why don't we go ahead and get started? Hello, everybody. This is my name is Arne Kumigai. I'm Vice Chair of Education for the Department of Medicine, and I have the privilege of kicking off this the first citywide medical grand rounds of the new year, and hopefully a better year than the last. This is a special citywide medical grand rounds that's devoted to the topic of Black health, and it is an endowed lecture. For this and to introduce the speaker, I'm absolutely delighted to turn this over to my fellow Vice Chair, Dr. Lisa Richardson, who is the Vice Chair of Culture and Inclusion. Lisa, please.
Thanks, Arno, and welcome to everyone. This is such a huge day and such an honor to be introducing Dr. Sean Wharton. I just wanted to say a few words about why we felt we wanted to have a lecture in Black health. As you know, our department is deeply committed to equity and well-being, and I thought, given that this is the week of Martin Luther King Day, I would just share a really beautiful Martin Luther King quote. So it's not possible to be in favor of justice and not be in favor of justice for all people. And our department has made the commitment to supporting the well-being of all of our faculty and learners and staff, and in particular to understand the needs and support the well-being of our Black, Indigenous, and other faculty and learners who are underrepresented. So in order to raise attention and raise the profile of our Black faculty, we're thrilled to actually have this to have a lecture every year, and this is the first year. And each year we will be honoring a different medical leader who is a Black physician. And this year that will be Dr. Miriam Rossi. And so to have Dr. Sean Wharton here to do that and to give us this inaugural lecture is such a pleasure. So Dr. Wharton has his doctorate in pharmacy and medicine at the University of Toronto. He's the medical director at the Wharton Medical Clinic, which is a community-based internal medicine, weight management, and diabetes clinic. He's also an adjunct professor at McMaster University in Hamilton and at York University in Toronto. He is also academic staff at Women's College Hospital, and he's clinical staff at the Hamilton Health Sciences Network. Dr. Wharton's research focuses on bariatric medicine and type 2 diabetes. He is the co-lead author of the Canadian Obesity Guidelines. Additionally, Dr. Wharton is involved in activism to achieve health equity in Canada. He founded the Black Medical Students Association at the University of Toronto in 2000, and the BMSA is now a recognized mentorship organization across Canada. Dr. Wharton is well known for his leadership work and as well as his clinical and scientific work across the country, and we're so thrilled to have you here. Thank you so much.
Sean?
Yeah, I'm on mute. Great. Thank you very much. This is terrific. It's exciting to be here and to do this talk. So I'm going to jump right into it. So thank you for joining me for this talk entitled Racism and Obesity Bias in Medicine, Similarities and Challenges. Here are my disclosures, my grants, my honoraria for academic talks, mainly for companies that are involved in obesity medicine. I also work for the Ontario Bariatric Network and a community diabetes and weight management clinic. I'd like to begin with a land acknowledgement. For thousands of years, the land in which the University of Toronto operates has been the traditional land of the Huron-Wendat and the Seneca, and most recently, the Mississauga of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and I'm grateful to have the opportunity to work on this land. This lecture is dedicated to Dr. Miriam Rossi. Dr. Rossi was born in Boston, Massachusetts. She and her husband moved to Toronto in the early 1980s. She worked as a pediatrician at the Hospital for Sick Kids and then became the Associate Dean of the University of Toronto in 1988. She was the first Black dean in Canada. In this position, she immediately felt the responsibility to ensure that there was appropriate representation of Black people within medicine. Therefore, along with Dr. Dominic Shelton, she founded the Association for the Advancement of Blacks within the Health Sciences, also called ABBAS. As the editor of the ABBAS newsletter, I had the privilege of interviewing Dr. Rossi about her mission. She was a trailblazer, and we work each and every day to walk in her footsteps. Dr. Rossi passed away in 2018 of Alzheimer's disease. So here are the objectives of my talk today. At the end of this presentation, participants should be able to, 1, describe bias and prejudice and its effect on medical care. 2, take steps towards minimizing bias within their practice. And 3, identify systemic racism within society and also medicine. So when Arno and Lisa first asked me to do this presentation, we thought that the topic should be about racism in medicine, but also about how it affected my life and why it led me to start the Black Medical Students Association. Well, I thought that was great, but I'm not a scholar in African American or African Canadian studies. So this was not going to be easy. But then I realized that I am a Black physician who's worked in activism from even before starting in medical school. And I can give my experiences and the academic information about this topic. I also decided to take some of the pressure off the intensity of anti-Black racism. I would talk a little bit about my academic field, obesity medicine, particularly obesity bias. I know a lot about bias within obesity medicine. I see the injustices to people living with obesity every day in my practice. I see the similarities and the challenges to anti-Black racism. But let's be clear, obesity and racism injustices are not the same. You don't get shot for having obesity. There was no slavery. And there are clear, effective treatments for morbid obesity, whereas a fix for systemic racism is very hard to come by. So this presentation is not to put anti-Black racism and obesity bias at the same level, but to call out injustices in each area. I will spend about a third of my time on obesity medicine and the bulk of the talk on anti-Black racism. So I thought to myself, I have to be the only person combining obesity and systemic racism. Well, not so fast. Just last week, Dr. Dan Drucker, famous Canadian endocrinologist and scientist, sent me this article. And in fact, Dan will be giving citywide grand rounds just next month. So he sent me this article. Yep, my friend Jamie Ard, an internist from North Carolina, just wrote this paper, COVID-19, Obesity and Structural Racism. I'm so proud of Jamie. He and I are one of the few Black physicians working in the obesity field. We are now going to share a lot of information about the US and Canada and how we battle similar problems. Throughout this talk, I will stop for calls to action. I'd like us to leave with actionable steps and not just contemplation. I will first talk about bias within the obesity field. In my residency program at McMaster around 2004, I was already interested in hypertension in Black Canadians and Black Americans and trying to understand why it was so prevalent, causing morbidity and mortality, which we now know is almost entirely due to racism within North America. As I was looking at this, I then encountered Dr. Arya Sharma, a nephrologist, who was also understandably interested in hypertension, but more so with the connection to obesity. I started to work with Dr. Sharma, and this led to even more questions about all the other conditions that obesity causes and what was the root of elevated weight. I decided to follow this research and clinical path. Very soon into my journey of obesity research, it became very clear that much of our lack of understanding of obesity was mainly due to bias against people living with obesity. We know that the inflammation caused by the white adipose tissue causes a significant number of medical conditions that range from cognitive decline to metabolic conditions such as diabetes and also cancers. Even acute conditions such as COVID-19 are significantly worsened by this inflammation. So why would such a prevalent, devastating disease go unstudied and untreated and frankly disregarded? It is because of weight bias and discrimination against people living with obesity. We'll be talking a lot about bias, so let's have a definition for it. If you Google bias, the definition comes up as prejudice in favor of one thing, person, or group compared with another, usually in a way that is considered to be unfair. Weight bias is negative attitudes and views about obesity and about people living with obesity. Let's look at the definition of implicit and explicit bias. Implicit is unconscious bias, and explicit is conscious bias. If you want to know, do I have implicit bias? You can take the implicit bias association test from Harvard. You can Google it. It is online. It's free. You can test for many biases, such as weight, race, gender, and sexuality. Here's the thing. Almost everybody has weight bias. So how can I be so sure of this statement? Well, studies show that obesity bias starts in preschool. If you show pictures to children in preschool of a child living with obesity versus a child with a disability, the preschooler will never choose the child with elevated weight as a playmate. They also start to assign negative attributes to those with obesity, including laziness, a lack of intellect, and other harmful traits. This bias continues well past preschool and is seen in doctors and healthcare providers. 70% of people living with overweight and obesity state that they experience stigma from healthcare providers. This is certainly a staggering number, and we know that this can be quite overt at times. So the call to action here is to recognize that you may have weight bias. Since bias and stigma are the major problem within this field, we decided to write the Canadian guidelines along with patients that kept an eye out for our biases. Pictured here is Ian Patton and the patient advocacy group. Ian is in the far right in a checkered sweater. He has a PhD in kinesiology, and his group told us that we, the researchers, were biased. And this has been documented in many studies, such as this study listed here. We took this message to heart and worked to ensure that each chapter was not biased and was not stigmatizing. Over 3 years, 62 authors wrote the new obesity guidelines published in the CMAJ August 2020. These guidelines have had an impact in Canada and around the world, likely due to the focus on weight, bias, and discrimination. The weight bias chapter is the first chapter in the guidelines, and the last chapter addresses obesity with Indigenous people. Indigenous people have the highest rate of obesity and diabetes and the worst care due to bias and systemic racism. Here's what I learned from the lead author of the Indigenous chapter, Dr. Lindsay Croshew. He stated that it is not obesity and the Indigenous, it is obesity with the Indigenous. There has to be inclusion. It is not done to them, but with them. Indigenous people wrote the chapter. We wanted to bookend these guidelines with these chapters and ensure that we included solutions and hope that we could do better. I'd like to give you a clear example of bias and discrimination from a family doctor here in Canada. This piece was written in the Medical Post in August 2020, shortly after the release of the guidelines. She states that losing weight is too hard because the general attitude of patients coming into her clinic is one of non-accountability. Not that there's a biological and genetic reason for elevated weight, but mainly blaming and shaming them and stating that they are not accountable. She also goes on to state that when she inquires about their diet, they're incensed when she tells them that pierogies are not a good choice. She suggests that we should paint billboards with simple common sense info to help these patients. This is a clear example of explicit bias leading to discrimination. Clearly, the biggest challenge facing obesity is a lack of knowledge within the medical field regarding the science and the biology of obesity. This ignorance leads to recommendations such as eat less and exercise more. This simplistic message does not address the biology of obesity. As a result, it does not work as a treatment. Obesity is a disease that lives in the brain. The 3 areas of the brain most involved are the mesolimbic system, or the hedonistic system, the hypothalamus, or the homeostatic center, and the frontal lobe, or the executive functioning center. All mechanisms of the brain are designed to drive weight up and to encourage a regain of weight if there's ever an attempt to lose weight. The intensity of these systems to protect against weight loss is driven by genetic factors coding for receptors and neurochemicals that promote weight gain. We're gaining a greater understanding of the brain, therefore we can develop treatments that actually work. There are 3 interventions: psychological intervention, pharmacotherapy, and surgery that all work within the brain neurochemistry. These treatments look like treatments we would see for other medical conditions, and that's because they actually are. There's nothing particularly fancy or different with obesity compared to many other chronic diseases. The only thing different is us, the doctors, and how long it has taken us to understand and treat this as a disease. Getting back to weight bias, knowing that there's effective treatments that follow biological principles helps us to eliminate this bias. Let's discuss stigma, often the reinforcer of obesity bias. If you Google obesity and images right now, you'll find that 72% of the images stigmatize people living with obesity, and that's a real shame. You'll see images of people wearing clothes that are too small for them, riding up their bellies, as if people don't know how to dress, or images of them in unflattering positions. This is hurtful, belittling, and should stop. Instead of these images, Obesity Canada has an image bank where there are free images of people living with obesity who are active, moving, and dressed in an appropriate fashion. These are the images that should be displayed. Last week, Friday, we got this exciting news. The obesity guidelines were the #1 most read article in the CMAJ in 2020. The majority of the 25 most read articles were COVID articles. So why were the obesity guidelines so popular? I don't really know, but I think it's because we called out the injustice in a medical field. I think it was embarrassing for doctors to be so far behind in any medical field. We were well behind psychologists, patient advocacy groups. They all beat us to the punch. We have some catching up to do, but it can be done. So the call to action here is to recognize your own weight bias. If you've not treated patients living with obesity with medication, surgery, or cognitive behavioral therapy, then you may have weight bias, because goodness knows you have a lot of patients with obesity in your practice. You'll see them this afternoon. We should work on eliminating stigmatizing pictures. They reinforce biases and discrimination. Gain a better understanding of the biology of obesity, its neuroscience, and our treatments need to follow these biological principles. We should put standard guidelines and treatments in place to change the course of this disease and to treat patients with compassion and empathy. Now, let's discuss my other passion, activism and anti-Black racism. This is the title of Dr. Ani Norm's recent commentary in the CMAJ. The title is Time to Dismantle Anti-Black Racism in Medicine in Canada. That's a powerful title. Dr. Norm is a scholar in this field, and much of what I have to say is documented in her terrific article. I want to start with the quote from James Baldwin. He was a writer and activist in the 1960s and 70s that put pen to paper about how we feel as Black people. Here's his most famous quote. Not everything that is faced can be changed, but nothing can be changed until it is faced. And that is what we have to do here, uncover the systemic racism in medicine and face it. Let's look at the definition of racism. Racism is defined as any prejudice against someone because of their race. But if we leave it there, we only deal with overt racism. The real issue is the racism that most of the world practices every day, and that is systemic racism. So racism should be defined as any prejudice against someone because of their race when those views are reinforced by the systems of power. So who in Canada faces anti-Black racism? 3.5% of Canada is Black. We're the third largest visible minority, and there are 4.7% of Black Canadians in Ontario. In comparison, 13.4% of America is Black. 43% of Black Canadians are actually born here in Canada. When we think of racism, we often think of overt acts of racism, such as lynchings, the actions of the Ku Klux Klan, or slavery. But Canadians are often smug, stating that there is no racism here. We don't do these things. While there is racism in Canada, and there was slavery here in Canada also, lessons for another day. But let's talk about what's happening now, today. In my view, police brutality is overt racism against Black, Indigenous, and people of color. This treatment is not subtle. It's extreme, it's precise, and it's the acts of a racist organization. The report by the Ontario Human Rights Commission in 2020 is clear. Blacks are 20 times more likely to be shot dead in Toronto by the police. The statements by many police chiefs are clear, stating that there is racism in the structure of their organizations. The need for reform is being realized in jurisdictions all across the US and Canada. This is no longer a question, is the police organization a racist institution? It's a reality that cannot be ignored. There has to be change. We demand change. So we've talked about overt racism, and now the question is posed, is there systemic racism within Canada? The answer is clearly yes. It is defined as structures or systems designed to be advantageous to the majority. Again, Canadians often state, at least we're not like the States in reference to racism. Anti-Blackness is a global pandemic impacting the well-being of Black people every single day, and anti-Black racism exists everywhere, and also here in Canada. Here's the thing. Systemic racism works with or without you. Systemic racism doesn't mean that there's lots of racists in the system. It means that even if there were zero racists present, the system would still disproportionately harm people of certain races. It is a machine that runs whether we pull the levers or not. By just letting it be, we're responsible for what it produces. So as Dr. Norm states in the title of her commentary, it needs to be dismantled. So why are you listening here today? To learn how to recognize overt racist acts, or to recognize systemic racism that threatens the progress of people of color in Canada? The problem that handcuffs us in Canada is that we collect very little data on race and ethnicity. We should collect university admission rates, home ownership rates, infant mortality, and maternal mortality rates. This is all data that's regularly tracked by the US government agencies. Historically, this was done due to the fact that Black slaves were property and had to be accounted for. Yet, if we collect this data, it would enable us to more clearly identify and intervene against the primary barriers impacting Canada's Black population. To understand why there's anti-Black racism in the healthcare field, we need to better understand that implicit bias I was discussing earlier. Our brain needs to make associations every minute by integrating data and grouping it. That's survival. These associations are mainly unconscious or implicit, and they can be created or taught. For example, if you see a nun and you're told the associated words are good, angelic, kind, non-threatening, that's what your association is. If you see a Black man and you are told thug, gangster, your association is again clear. You're now treating both of them in the emergency department for shortness of breath. You may give the nun lots of time and good treatment. For the Black male, you may cut him off short and ask, well, do you smoke? Well, let's look at some studies that document this implicit unconscious bias. This is a study done in 1999 by Kevin Schulman, looking at the effect of race and gender on referrals for cardiac catheterization. These were all actors, white male, white female, Black male, and also Black females. They were all given the same script: crushing chest pain radiating to the left arm, a sense of impending doom, sweating. The scenarios were shown to internal medicine doctors at a conference. They had to decide the treatment of the patient. Here we can see that the white males were given the option of cardiac catheterization the most. If you were female or Black, the odds ratio was 0.6 chance of getting a cardiac cath. When looking at both race and gender, the differences were primarily driven by the fact that Black female had a 0.4 odds ratio of being referred for cardiac catheterizations. Black females got the short end of the stick for no other reason beside implicit bias against Black females. Well, that was a long time ago, 1999. Things may be different now. A 2019 study by Dr. Quinn Capers, a terrific cardiologist in the States. A 2019 study looked at 4 million records of patients that got an angioplasty to see who got it late versus early, adjusting for confounding factors. The earlier you get a plasty done, the more cardiac muscle you will save. The data show that the factors that determined a late angioplasty was 1, female gender, 2, Black race, 3, weekend admission, and 4, private insurance. In other words, being female was as bad as not having insurance. Being Black was as bad as not having insurance. But being Black and female was again the double whammy. It appears that things have not changed, particularly for Black women. What about here in Canada? Dr. Norman and Dr. Lofters here have shown that Black women may be underscreened for cervical and also breast cancer and may be predisposed to worse outcomes. I've researched this disparity within obesity medicine also. We looked at the results of weight management, the results of my weight management clinic in over 9,000 patients. We found that overall, women of color lost less weight than white women did. When we adjusted for the number of visits to the clinic, there was no difference. So the issue was access to care. We could not reach them, they could not reach us. The system was not built for them, but for those with privilege, the ability to take time off. We have been working on solutions to correct this by starting to use virtual care to reach women in their homes and also at work. The medical events of 2020 has brought systemic racism to light in Canada and also America. Those most affected by the virus are the marginalized groups, Indigenous and Black people. A study is being conducted by Dr. Upton Allen at Hospital for Sick Kids to look at this issue. They estimate that 21% of those affected by COVID are from the Black community, while Black people make up 9% of the population within this city. This disproportionate representation is likely due to systemic biases, including the fact that many minorities work in essential labor jobs and cannot work from home. Also, the systemic biases within healthcare, leading to poor health and higher risk, and a lack of access to care. So to try and correct the implicit bias within medicine, would physician diversity matter? This study looked at this question. They asked Black men, who were the patients, to see doctors from various ethnic backgrounds, a Black doctor, a white doctor, or an Asian doctor. All doctors were instructed to give the patient advice on preventative care, the flu shot, healthy eating. The study found that the Black men were more likely to follow the recommendations of the Black doctor. The advice may be more valued. There is a Black-white gap in cardiovascular mortality within men within the States. This study has suggested that this better care could reduce that gap by 19%. They also looked at the notes from these doctors. The non-Black doctors wrote very short notes, oftentimes one word, weight loss or anxiety. Meanwhile, notes from the Black physicians were longer, they were more detailed. Needs food, shelter, clothing, and a job. Patient yelled at me, but agreed to get a flu shot because I recommended it. Made patient laugh. You can see that there is likely a different relationship occurring with the physician and their patient here. To that end, how do we address increasing the number of Black physicians in the system? The suggestion is to address the leaky pipeline within the education system. The idea of the leaky pipeline is that we're losing quality Black students at an alarming rate, often due to systemic racism within the education system. Examples: Canada's most well-funded school exists in predominantly non-Black neighborhoods. The gap between Black and non-Black student achievements is growing, and there's evidence that much of this is steeped in anti-Black racism. From 2017-2018 Toronto District School Board report shows that 34% of all students who were expelled from the Toronto District School Board were Black. Black students make up only 11% of the Toronto District School Board students. The school board executive, Jim Spiriopoulos, stated that systemic factors of race and poverty find their way into the school system and factor into these expulsions. We have to start addressing the power, privilege, and bias in the system. So what are the solutions? There's no single solution that can undo hundreds of years of racism. And solutions will need to come from a wide range of places, organizations, and also individuals. I've been told to make a good presentation, you have to tell stories. So I'm going to tell a story about how I made it into medical school and started the BMSA as an example of a solution. I'm an immigrant of South America, British Guyana, an impoverished British colony, part of the West Indies and the African slave trade. It is often funny to me to realize that most people are unaware that any Black person without an African name got their last name from a slave master. We were from the Wharton plantation from the late 1800s, originally from Barbados. My dad trained as a physiotherapist in London, England, and we immigrated to Canada in the 1970s for a better life. Unfortunately, my parents split up shortly after we arrived here, a very amicable split. My father stayed in our lives and was a big part of our overall education. But to raise 3 children in a new country was not easy. So we had to go on welfare and move into the projects. My dad's meager income could not help much. We stayed on welfare for 5 years while my mother went to school and got a BSc degree and also a teacher's college degree. These years were actually great. We had lots of great friends and also excelled within school and also sports. Here's my privilege. My parents' families are highly academic, and our welfare house was like a little university within the projects. Things were good for us, and we also got lucky. But life was different for some of those who were also bright and capable, but got left behind. I graduated from pharmacy, the University of Toronto. I was the only Black student in my class of 170 students. Very disappointing. I practiced for a while as a pediatric pharmacist and then did my doctorate in pharmacy and finally moved on to medical school. Upon entering U of T medicine, it was frustrating to again be one of only 3 Black students out of 270. We were 1% of the entire class. Here's Michaela and Ketrin, PJ Galawango, and myself. I jumped right into activism. The first challenge was tuition deregulation, which meant the fees were going up from $5,000 a year to $25,000. So of course, we knew who that would affect the most, racialized groups. The quote in the newspaper, students fear that the medical profession will be reserved for the rich, excluding marginalized groups. As vice president of the student union, we organized marches with our allies. We lost the battle, but it was a good fight. I turned my attention back to the issue of underrepresentation of Black medical students. I started the BMSA in the year 2000, along with the other students from the other years. We were 8 students in total out of 1,080 students. So that's less than 1%. The mission of the BMSA was to engage with undergraduate students and mentor them for entry into medical school. We also wanted to provide support to the few that we had within medical school. We had success in increasing the number of Black medical students, and we've stayed strong for 20 years and ongoing. Each year, another group, sometimes small, between 1 to 6, would do the hard work of the outreach to the undergrads. We did have some fun. Here we are acting like the Temptations or the Pips, if anybody remembers Gladys Knight and the Pips. Over the years, we have seen the development of programs designed to reach the goals that the BMSA had the audacity to dream of. Thanks to Ike Okafor, who started the community of support to address mentorship and offer guidance. We also are fortunate to see the work of Dr. Lisa Robinson, Associate Dean of the University of Toronto, for spearheading the BSAP, or the Black Student Application Program. The community support offers support to marginalized students at every stage of their journey. Here are the key things they do: provide admission information, build competency through volunteering and research, support students with applications such as a mock interview or helping them with the MCAT prep. The Black Students Application Program encourages members of the Black community to be part of the file review and interview process. These are Black physicians, professionals, scholars, and members of their broader members of the broader community. And why are they at the interview process? Well, there's recognition that a lack of diversity and inclusion will continue in medical school and other professions when visible minority leaders are not present at the table. So here are some of the results. U of T Medical School went from 1 student in the class of 2020, Chica, also the class valedictorian, and now there are 25 students in the class of 2024. When I think of what Ike and Lisa do, this picture comes to mind. This is a slide from Ohio State City Schools, where they have medical professionals going to schools to encourage kids to achieve and to consider medicine. Ike and Lisa do just that. They reach back, address the leaky pipeline, and give hope and also encouragement. Recently, I started this scholarship to recognize that no student should leave medical school due to finances. This almost happened last year to a second-year medical student, and we rallied to raise the funds. In the year 2020, I started the BMSA scholarship. I donated $25,000 to the fund, and it was matched by a generous U of T donor to $50,000. And many alumni from the BMSA and allies continue to donate to this endowed scholarship run by the U of T. I remember needing help, and I got it. A loan from the Alumni Association in my 3rd and 4th year. It was a lifesaver. I'm proud of starting the BMSA 20 years ago. It has now grown from just U of T to across Canada. Here's a picture of the inaugural national meeting of the BMSA. This was in February of 2020, before COVID. Oh, wow, was it ever nice before COVID? So what can we do? Let's support the organizations that do this hard work, as it takes a village to get us to this goal. On February 27th, the second last day of Black History Month, the BPAO is having their annual education symposium. Please attend. Our own Dr. Ani Nuram is president of the BPAO, and I am on the advisory board. And the very next day, February 28th, the BPC, Black Physician of Canada, is having their first annual symposium. I will also be there. So what can you do that is actionable? Accept that Canada has systemic racism within education, healthcare, and also in policing. Possible solutions. Let's work towards collecting race-based data within Canada. Let's implement programs that assist mentoring and recognition of diverse candidates. Let's support the organizations that do the work to dismantle anti-Black racism within Canada. So in conclusion, we started the presentation with the discussion of weight bias. We know that weight bias in obesity medicine is real. It stalls research, treatment, and harms those living with obesity. Stigma and stereotypes are hurtful and perpetuate implicit and explicit bias and prejudice. Anti-Black racism exists within healthcare in Canada, and there are solutions to it. We can do better. We should do better. I will end this with another James Baldwin quote. This quote is important because there will be people that disagree with my presentation, with my view. My views are clear. There's no systemic racism in the medical system or in policing or other statements. So what can we do about these disagreements? Well, James Baldwin stated, we can disagree and still love each other unless your disagreement is rooted in my oppression and denial of my humanity and right to exist. So this fight for equity will not stop. It can't stop. And listen, I do get it. This is a fatiguing exercise. But if you are tired of hearing about racism, imagine how tired people are of experiencing it. Thank you. This is my son, James. He's 4 months old now and has taken to raising his fist in a show of solidarity. My hope for him is that he has a better life as a Black boy and eventually a Black man in today's world. Thank you very much.
Thank you, Sean. This is Arno Kumigai again. I am deeply, profoundly grateful for your remarks. And I think you really illustrate this really critical nexus between society and societal impact of different things such as oppression and racism and the medical conditions that we work so hard to treat. So I think this was actually perfect. And it's also perfect because it happens on the same day and is competing with the inauguration of a new American president who hopefully will usher in an epoch of hope. I'd like to open it up to questions. There are already a couple in the question and answer function. So if you could please go to the question and answer function, include them. We'll try to answer as many as we can. And I will go ahead and start. The first question is, what is your view on advertised cognitive behavioral therapy apps such as Noom for obesity?
Great, that's a terrific question. I really like it. I think that obesity is a pandemic, right? There's 600 million people across the globe suffering with it, and it's not stopping. And we've had no stop to it whatsoever. So it's just going to become more and more. Fatty liver is going to become significant. Every condition connected with it has become more significant. So we can't stop it by just having a couple internists or specialists do it. So that's wrong. That is out. Has to be family doctors doing it because it has to be all of the medical field. Then it has to be nurses. Then it has to be computerized systems, and it has to be apps. So we have to look at systems that can do it in a much more effective manner. So I actually really like Noom. The one part about Noom that I'm not so crazy about is the counting calories part. But many people are still attached to that counting calories. We don't want people counting calories. We want people eating healthy and thinking about the other things that affect lower calories. And that's the cognitive behavioral therapy, about understanding what are some of the coping strategies, why you're sad, why you're eating for different reasons. When you do all of those things, the calories will come down while you're eating healthy. Counting calories is not it, but Noom is a good app. I agree with it.
Great. Thank you. Next question. From Karam Jessa. Dr. Wharton, with all due respect, I think the slide that you presented on obesity treatment was biased. Focusing on CBT and exercise underscores the oversized importance of nutrition and the role of insulin. Eat less, exercise more doesn't work for everyone. Care to comment?
Yeah, I'm curious as to, sorry that she said that the slide was biased because it mentioned CBT.
And let's see, it was mentioned CBT and exercise, which which the questioner felt underscored the oversized importance of nutrition and the role of insulin. So there was too much emphasis on CBT and.
Yeah, I don't think that. I think you read the slide wrong. I'd be happy to actually send that slide to you, so I can go over exactly what it is. What we know is that if you just focus on a diet and exercise, then you unfortunately put people into a position where you're not talking about the biological processes. So there's been studies shown that if you take a bunch of medical students and you talk to them about the nutrition and exercise when you're talking about weight changes, or you take another group and you talk to them about the biological forces and how the brain works, which group will be more stigmatizing, more biased, and blame and shame the patient more? The group that learned about the nutrition and exercise, the group that learned about the biology and the genetics and the treatments that are effective within the brain, they are less stigmatizing to the patient, have less biases, and treat the patient with appropriate treatment options. So frequently, nutrition and exercise, which is an excellent thing to do for our entire life, is super important, is not, when it comes to morbid obesity, causes oftentimes biases.
Great, thank you. Just a comment from Andrew Morris. So inspiring Sean, great talk. It's so great to learn from you. Comment from Dr. Jennifer Bryan. Excellent talk. Thank you. Can you update us on what's happening with race-based data collection in Canada?
Right. So we would like to see much more, and there is the race-based data collection is not just missing in Blacks, but it's missing in the Indigenous population. So we need to do a better job of going on to the reserves. We get off reserve data oftentimes, but not actually on reserve data. And I remember working at MAC with Sonia Anand, even to get South Asian data, we just had to look at last names in the phone book to try to figure out which last names were the South Asian last names that belong to a particular group. But you can't do that with Black people because, as I pointed out, our last name is a white last name from a slave nation. So Wharton doesn't tell you anything. There are more white Whartons in Canada than there are actually Black. So how are we going to actually do this? Well, this is work at the Health Canada level and at the federal level to be able to ensure that above and beyond just the census data, but the actual health tracking data, which we do have health tracking data, we can do a better job of at the family doctor's office and at multiple other areas.
So, John, when I moved to Canada from the US, I was actually surprised to find out that there weren't data being collected. This is wild speculation, but any idea why there hasn't been data collected on this?
Yeah, and it's great because of the article that I quoted in the presentation. So if you get a copy of the presentation, just look at that article there. They present a whole list of reasons why Canada, because Canada felt that it is an inclusionary country, that they don't need to collect the data in a manner, but without collecting it, obviously we run into the trouble of the fact that we don't even know that we have systemic racism or bias, because we just, every day for people with privilege is a great day. But if you don't, but if you are somebody living in a marginalized group, it's not a great day every day, and no one is collecting that. So Canada does a disservice by not collecting it. I understand in the States, it was because of property reasons. Black people were property. You had to account for them. There were multiple reasons for it, but it is turned into being able to tell us more appropriately where we stand and what we can do to make things better. So we have to change here.
So a question from Jillian Hawker and a comment. I'm frustrated with the lack of data, as you note, in the makeup of our department. Can you speak to the approach you might take to gather these data respectfully and safely?
Yeah, so I do think a lot of it is challenging. What we have done is we collect race-based data at my clinic. Every patient that walks into my clinic is a research-based patient. We ask them to sign off. What can we do research with your data? And we ask them race-based data. We ask them, do you self-identify as a Black? Do you self-identify as a Black Canadian, a Black African, a Black West Indian, South Asian? We go through it, and so I don't think that that's an impossible data to actually get. I think people are willing to actually give it. I think we're in a position where we're acting as if we don't think that people want to give this information, and it would be intrusive to them. I remember that there was a census done that came around to the house, and these two young people came. They were doing the census, and here is a short form. Can you fill it out? And I said, you know what? Can you bring me the long form? And the next day they said, yes, we can. Actually, it's going to be great. So they went back, and the next day they came back with the long form. I want to be in the data. I want to be a stat. Black people, people of color want to have their data collected. So I think we need to change.
A comment from Indra Narang. Thank you so much for an excellent talk. We need to engage our marginalized communities in research, as they have been actively excluded in studies due to reasons such as racism, language barriers, etc. How can we engage these communities as well as convincing our researchers that this is essential?
Excellent. So it has to be mandated. So what I've recognized within my own clinic is that I can't count on myself to not have weight bias. So when I see a patient, I'm in this world just like everybody else is. So I've got my own weight biases when I see somebody with elevated weight. So what we've done is we've decided to put in standard questions that allow me to not act on my weight bias. So that's what you want to do. You want to figure out, is there a rule that allows me to not act on my bias? So I put that in my clinic for weight. Let's put it into the research articles and the research projects, which they try to do in the States. At least 15% of your research project needs to have people of color, needs to have Indigenous people. Go out and find it, go out and do it. Yes, I've spent some extra time, some extra money, but this is not an option. If 5% are not Indigenous people, you don't have a study. If 5% are not people of color, 10% of people of color, you aren't going to publish the study. So that's what we need to do. I think we need to look at again, federal levels and Health Canada putting systems in place to help us to do what it is we want to actually do.
Great. Thank you. This is a great comment and a provocative question. How do we approach the deans of medicine, program directors of residencies, programs, etc., as they continue to argue that incorporating anti-racism within the curriculum is a task that is difficult, and when they continue not to have Blacks at the table?
Right, it is difficult, but as James Baldwin said, we have to face it and we're going to make mistakes. So that's what we need to recognize, that I'm going to make mistakes, and over the past few months, I've been asking people to look at my presentation. You can't imagine the number of mistakes I make. Imagine the number of mistakes my father makes, my other, when we talk about Black people, we use the wrong terms and we mess up. And we're like, so what we use now is this term called woke, which means that you are now awakened to the injustices within the society. Oftentimes they're referring to anti-Black racism, but within Canada, it means Indigenous population, it means women's issues, etc. So can you be woke? And the more that you can try to be there, the more that you can find out about the right things to do, the right things to say, shows that you're using your privilege. I have some privilege. That my family had, and a number of other people have other significant privilege. Use your privilege to find out more about what you can do with it to make a actual change. We can change. Are you kidding me? We can change education system. That's not going to be a problem. I think Lisa had a question as well.
Lisa, do you want to unmute?
I don't want to jump ahead of everyone else though, Arno. I accidentally put my question in the chat.
Oh no, that's okay.
So,
Since you're co-moderator, please.
Okay, so and now I'm going to find it. Sean, thank you so much for a phenomenal presentation and for awakening us to thinking about our bias, particularly around obesity, but obviously in our practices and around structural racism too. I wondered actually if you could speak a bit more about the intersection between structural racism and obesity. You spoke about your paper that you published in 2016 around visits to healthcare providers, perhaps as being one aspect of it, but are there any other factors that you think are contributing to that obesity epidemic, certainly in our communities, Indigenous peoples, but also for others who are BIPOC?
And the intersection, yeah. So what we've recognized, and Jamie Ard's article really talks about it, and because there are so much data in the States, he's able to track it from slavery to understand why this has happened. So if we look at obesity in the States, the highest group with obesity are the most marginalized group. So who do we think it is? Black females. Black females have 80% overweight or obesity. Now, the overweight part is probably not an issue because being a BMI of 28 as a Black female is perfectly normal. You don't run into metabolic conditions until your BMI is over 32. But if we look at the obesity rates, it's 44% in Black females versus 28% in white females. That's a huge difference. And the Hispanic women have a major challenge as well. And this is primarily due to the racial structures and within the systemic racism. We look in Canada, the Indigenous population have the highest rate of obesity. And so they keep on paralleling each other on a regular basis. Whoever is at the bottom of the barrel and getting affected most by racism on a daily basis, microaggressions, intensities, is going to be at risk of challenges with self-esteem and coping mechanisms and the eating behaviors and the hedonistic part of the brain that's always saying, wait, go up, up, up. So we have the Indigenous and we have the Black females running into significant challenges. That intersection is a problem, and we can fix it. We have mechanisms to fix it, and it's reaching them and being kind to them and being compassionate to them. That's our first fix.
So just some comments, a lot of praise. We're getting flooded with comments and questions. I'm sorry I'm not going to be able to address all of these. Mary Norris says there's a Black Lives Matter fund at the Dalalana School of Public Health that she encourages to do the same. Jackie James says, what are some good strategies about prevention of obesity? Are there differences depending on ethnic and racial approach? We know that obesity develops. We know that once obesity develops, it is difficult to manage.
That's a beautiful question. I'll answer that very quickly. We don't know how to prevent obesity. The field is still relatively new. What we know is that there's genetic coding that we now know at around age 8. We can tell somebody who has at 8 years of age whether their weight is going to be a major challenge later on. So now that we know, what do we do? How do we prevent it? We don't know. So the use of medications is a significant issue, a significant thing that we're thinking about. But also the bigger thing is going to be the connection with the person and the family. So we see that church groups tend to do relatively well, bringing people together. Small groups, and so groundswells do well. National things don't seem to do all that well, or big school-wide projects don't do well, but smaller projects tend to do a little bit better. And that's usually because there's love there. There's love and connection and care for the person and for the young child, telling them that you care about them. And that's a major part of this entire system.
So again, we are wrapping up. I've moderated talks like this for about 5 years now, and we have rarely gotten this number of questions. So I apologize in advance to the audience. We're not going to be able to answer a lot of these, and a lot of them are just words of thanks and words of praise, Sean. One of the comments, thank you so much for this talk. I was wondering where we can be directed to get more information on the research or other work that you are doing, particularly in the areas of stigma and obesity and race. Also, would it be okay to share some of the information learned today? And if so, how would you like to be credited?
Oh, that's a great question. So first of all, my email address is sean.wharton@utoronto.ca. So send me an email. I'll send you the slides. I like people using my slides, not PDF slides, but my real slides. So I'll send them to you because I want you to actually use them. And if it's good enough slide, you'll say, hey, it was Dr. Wharton's slide. So that's how you should credit me. I think that so Dr. Norum is starting a website that will have this kind of information on it. It will have talks. It will have some more information about what's happening, even the vaccine hesitancy within the Black population because of the mistrust that a number of the Black people have faced throughout the years is a major issue. That will also be on there. So Dr. Norm's website is going to be great. Connecting with me will be good. And I do think that if you go to Instagram, BPC, the Black Physicians of Canada, they have an Instagram page that has just been full of really good information to help us to navigate this anti-Black racism, which is new for the majority of people who are listening to. We know it's a problem, but how deep have you gone into it? How woke are you? Where are you? Where are we on it? Because there's so much to know, and it's and it's good stuff to know. So please go to that as well.
To the very last, I know that we're a minute over, but I have to say this. This is coming from a medical student. Thank you, Dr. Wharton. It was very insightful and important presentation. As a first-year medical learner myself, could you share your experience and provide some advice for medical students who are trying to advocate for changes in the medical curriculum hospitals, but are prevented by bureaucracy or stopped by a lack of interest and engagement from faculty? So 3 words, what would they be?
Right. So the 3 words would be recognize when it happens and don't be afraid to speak up, even if you're wrong. So we've learned that most of the time, if you think something is a little off, it likely is. So don't be afraid to speak up. Be more woke, wake up to look at it with a different lens. Now you'll see it.
Thank you, Shauna's beautiful summary. So again, thank you, everybody. We've had over 200 viewers to this Medical Grand Rounds, one of the records that we've had in the department since I've been here. Just an absolutely great, inspiring talk. And so thank you to the audience. Thank you, Dr. Wharton. Thank you, Lisa Richardson, for spearheading this. And thank you to the department, Julian Hawker, for supporting such an important event. So thanks,
Thank you very much. Thank you very much.
Take care. Be safe, everybody. Thanks a lot.